is focused on production of biofermented hyaluronic acid of high molecular weight. We are located globally with the headquarters in Switzerland and in India. As you can see in the map, we are connected worldwide with basically everywhere people have access to our products. Our sales headquarters are based in Switzerland. Also, we have our offices in Turkey, in Ahmedabad in India, Kartai, Changorat, and Roscommon in Ireland. It is our newest facility. It's also our R&D facility, also in Brazil and Bogota in Colombia. Company basically every year have achieved very good milestones that makes company so well known and so well prepared for the market with millions of satisfied customers. Company is focused on three main sectors: ophthalmology, dermatology, and orthopedics. In orthopedics, BioTech's offering the full range of vasculosupplementation, the intra-articular injections from multi shots to single shots, from 20 milligrams to 40 milligrams, with to even 90 milligrams and 40 milligrams with mannitol. Companies also have also CE marked, so it's obviously a proof that we are very concerned about our quality, and we are thinking wide to be able to sell our products worldwide. This is very important. We are investing very much to educate our customers, our clients, doctors. We are organizing live surgeries and symposium. This is very important. We are not only a selling company, we also want to educate people, educate our users. This is very important thing. We want to be a partner for our doctors. We want to give you the best knowledge as possible. We give you the best product. We give you the best results for your patients, which is very, very important. So I would like to first introduce our fine first speaker, which is Professor. Let me just. Oh, I'm sorry. I'm lost with this software. I'm sorry very much. Just wanted to stop sharing, but from some point I can't do this. Can someone? I'm sorry very much. I'm really sorry about this. I don't know. So let me first introduce our first speaker. That will be Professor Tamilkovsky. He's a member of many associations. Is working as a professor at medical faculty at university at Macedonia in Skopje. He's fluent in French, English, Serbian, and Bulgarian. His most fields of interest are knee surgery, sport traumatism, arthroscopy, surgery of shoulder and knee, endoprosthesis. He's a member he's a member of many national, international associations like Macedonian Association and Bulgarian Orthopedic and Trauma Association, where he's also an honorable membership. He's also honorary membership of Bulgarian Orthopedic and Trauma Association, but also, what is very important, he's author of 2 books, Shoulder Biomechanics and Clinical Investigation, and co-author of a book of Unstable Patella Diagnosis and Treatment. So I will now like to ask Professor to start his presentation.
Okay, Piotr, thank you for nice introduction to me. And I'm very sorry, but coronavirus is very present in Macedonia. And in a couple of hours, all the police in Macedonia lock down our country. Maybe it's not problem only in Macedonia, the problem is in all of the world. And now we will start with my presentation. Hyaluronic acid and knee. Check. Не можем да ги въртам. One moment. Okay. What is the clinical need for the cartilage repair, especially in a young patient with a condition leading to osteoarthritis? You know, sports injury like a fracture of the joint, of the knee joint, fracture of the cartilage lining, and the disease of the cartilage like osteochondritis, chondromalacia, early osteoarthritis. And then what is the vital joint structure is articular cartilage, subchondral bone, synovial membrane, synovial fluid, capsule, and the ligament. What is the function of the cartilage? Low friction of articulation, shock absorption, and minimize stress of the subchondral bone. What about the structure of the human articular cartilage? You know, water is maybe 80%, extracellular matrix is 20%, chondrocytes it is 5%. In summary, it means that human articular cartilage consists 20% collagen 2, water 75%, and cells are only 5%. But what about history about cartilage damage? You know, in the 18th century, William Hunter said, when destroyed, it's never recovered, but it was two centuries ago. And maybe 2,000 animal study and clinical observation is done until now about the possibility to solve the problem. And James Paget make a very nice question. May the articular cartilage heal? Yes or no? We'll see in the next presentation. But when you talk about interarticular lost body regarded, especially during the synovial chondromatosis, we find that a lot of cartilage cluster in the knee joint. And then when you see arthroscopically, we have one simple question. Why do not we produce our own cartilage is our own body? And who will be responsible for that? Maybe synovium. Why synovium? Because synovial tissue have less advantage than another tissue in the knee joint. It's most chondrogenetic, highly proliferative. It's nearest to the articular cartilage, and they have easy access. Synovial membrane is composed of vascularized connective tissue that lacks a basement membrane and contains 2 predominant cell types, which reflect their function. Type A cells, important in phagocytosis, and type B cells, it's very important in fibroblast-like cells, which produce synovial fluid. We have type C, but never mind. Type B cells produce the synovial fluid. Synovial fluid is an ultrafiltrate of a blood plasma containing, in addition, hyaluronic acid. It's very important. We talk about that. Proteinase, collagenase, and prostaglandins, but not blood cells, clotting factor, or hemoglobin. What is the function? Nourishment of the articular cartilage through the diffusion, lubrication of the joint surface. What kind we have with the cartilage? The first symptom is a pain. We call anterior knee pain. We talk about patellofemoral pain syndrome, and cartilage have a little repair capacity. What about natural history? Shelburne, my colleagues from United States, make us in simple sentence there's little scientific evidence to suggest that a symptomatic lesion will become symptomatic in the future. What is that? It's very important because we must stop the little scientific evidence not to be symptomatic in future. What is that about injured to articular cartilage held by scar tissues? But in my opinion, it is pseudocartilage. Pseudocartilage is deficient in type T collagen. Inferior biomechanical characteristic, lower load bearing capacity at inevitable short-term recovery. What we do know up to date that articular cartilage is avascular, aneural, and has a small capacity to repair. Chondrocytes in intact cartilage have a little migration of mitotic capacity and do not feel cartilage defect. Injury involving subchondral bone result many times in related to MSC production of repair fibrocartilage with inferior biomechanical property. Where is the place of hyaluronic acid in human body? We measured in healthy young synovial young sportist synovial fluid that the molecular weight is 4 to 5 million Dalton, and lubrication viscosity is 550. In osteoarthritic synovial fluid is 0.5 to 4 million, but rare, and lubrication is too small. What is that with the hyaluronic acid like Optivisc single is 3 to 3.5 million. It means it's the same value as a healthy young sportist. How big is the problem here? You see from the literature from, for example, Aaron, American Journal of Sports Medicine 2004, it means 1,000 arthroscopy, 66 cartilage damage. Hell, an arthroscopy 2002, 1,000 arthroscopy 20. It means is the problem is big, and we want to solve this problem, to stop the osteoarthritis as soon as possible. What about new technological advance, second generation tissue engineering technique, characterized cell size, matrix design, collagen, hyaluronic acid, calcium, PRP, PRGF platelet, rich plasma. My colleague from Sweden, we went together to Belgium, to Professor René Verdon Galquist in 2011, give us a small review about the biological solution. And the non-biological solution, as you know, is possible, but biological solution is very interesting about the bone marrow stimulation, cell-based approach, and acellular scaffolds. About the non-biological solution, we have everything then arthro surface system. What is the possibility of treatment today in my country, in Balkan Peninsula? Because I was a president of the Balkan Association, and we make some regulation and protocol how to treat. The possibility is, for example, autologous chondral implantation, AC, and it is for my student to see this slide, and AC with the fibro-Baxter tissue call. And then MACI, matrix associated autologous chondral implantation, final result. And we use collagen filler for cartilage supplement in this young patient. But I put all these slides to see that the procedure is very aggressive and expensive. And what is the possibility to treat with hyaluronic acid? In hyaluronic acid in the human body, you see of this slide, you can use in cosmetic ophthalmology, dermatology, in rheumatology, and normally in orthopedic surgery, especially in treatment of early phase of osteoarthritis, because the hyaluronic acid have a tissue regeneration possibility, biocompatibility, hydrocapacity, and viscoelasticity. When we talk about the knee joint, about this slide, a lot of our viewer and the resident, they see where is the place of the hyaluronate in the knee joint, especially in the cartilage of the knee joint. What is that about your product, Optivisc, and what is the benefit to use that? The indication is indicating the treatment of pain in osteoarthritis, and for me, I add chondromalacia of the knee in the patient who have failed to respond adequately to conservative non-pharmacologic therapy and to simple analgesia. High molecular weight, we see that 3.5 million Dalton is similar to the healthy young person, sportist or young man. The viscosity is 750 with the Optivisc 90 milligram is higher than synovial fluid, maybe double. And the product from the bacterial fermentation. What is the mechanism of action? Psychological and pharmacological mechanism and effect of hyaluronic acid in the synovial fluid. It's restore rheological property and the metabolism of fibroblast, maintenance of lubrication, maintenance on viscoelasticity. It's a very important. Exert anti-inflammatory effect, a reduced production of the activity and other pro-inflammatory mediators is very important to stop the osteoarthritis. Hyaluronic acid mechanism of action of physiological and pharmacological mechanism in synovial fluid continue with the inhibits synthesis of PGA2 and bradykinin. Hyaluronic acid mitigates synovial hypertrophy and increase the number of synovial fibroblast-like cell. You see, fibroblast-like cell is type B cells. They produce the synovial fluid. Regulator fibroblast proliferation and inhibits migration and aggregation of leukocyte and macrocyte. Hyaluronic acid mechanism of action, again, alter behavior of immune cells, enhance synthesis of chondrocyte, hyaluronic acid, and proteoglycan, improve viscoelasticity, and enhance lubrication, improve joint function mobility, and reduce the stiffness. The stiffness of the knee is always a problem for all orthopedic surgeons. Hyaluronic acid interact with the hyaluronic acid receptor or on around the 3 therapy producing analgesia. What is the benefits when we use Optivisc like a hyaluronic acid with the big molecular? Effective free radical scavenger, protect chondrocyte and synoviocyte from further degeneration, stabilize cells membrane, helping in maintaining favorable environment for the synthesis of the normal hyaluronic acid. Replace pathologic synovial fluid. I told again, replace pathologic synovial fluid, because Optivisc have a 3 milliliters, and normally in the knee joint, small knee joint, we have approximately 6 milliliter of synovial fluid. Replacing with a good with a high million of Daltons, it means 3 to 4 million, and the supplement elasticity and viscosity, and reduce the pain, improve mobility, and protect the cartilage. It means it's done a good quality of life of the patient. Thank you very much for your attention. I'm here to about all questions from the audience and our resident.
Thank you very much, Professor. That was a great presentation. Now I would like to encourage our audience to ask the questions. You have a text box below your video, and please put any questions you have to Professor about his presentation or maybe your experience, if you like to ask. And this is the right time when where Professor will be able to answer those questions. So please feel free. From previous days, there are some questions already in our form. The first question is, what molecular weight is the exact for the knee? This is the first question to the professor.
What's the molecular weight?
Yeah, what molecular weight is the exact for the knee? Probably what kind of molecular weight is indicated for the knee? What would be the best for the knee?
I have 64 years old. I'm 64 years old. For a young patient, maybe it's good to be between 4 and 5 million Dalton molecular weight. It is the reason why I prefer injection with a higher molecular weight, like Optivisc with 3 to 3.5 million. It's very similar to the young patient, even though if I will be the patient, I'm not yet patient. For me, it's enough 3 million Dalton.
Thank you very much, Professor. There's another question. Is steroid safe for knee injection for often usage?
When we talk about a corticosteroid like Depomedrol or another type of production, my opinion is that all the pain starts in synovium. It means it will be nice to solve the problem, the inflammation of the synovium with the cortico, but single use. And after 2 weeks, it's good to continue the therapy with hyaluronic acid. But when I use for the hip joint, I have obligation, because in hip joint I put under the radio control. I put the first anesthetic, then cortico, and then Optivisc. Because in the same time, I believe that I solved the problem with the synovium of the hip joint, and with Optivisc single, we solved the problem about the Daltons inside and the pain, and we have maybe 100 patients or more. They are very, very satisfied with this kind of therapy, together with anesthetic, cortico, and visco supplement. And in Macedonia, we have some regulation about the supplement. It is a medical-based evidence. Viscose supplement in hip and the knee joint, it's regulation, like a medical-based evidence, no problem. But I said about hip joint, because the pain starts in hip joint with the synovium, not with the cartilage. And we must solve the problem of the pain, of the inflammation of the synovium, to produce good quality of synovial fluid, B cells, it means.
Okay, thank you very much, Professor. Some new questions appeared. So what is more effective, a single dose or 3 divided doses of hyaluronic acid injections?
It is a good question. Sometimes when we use single dose of 20 milligram, 5 shots. 5 shots, it means 10 milliliter inside of the knee joint, this big knee joint. Sometimes you have a big contents inside of the knee joint, and prolongation of the therapy, it means 35 days, every 7 days, is 5 shots, is 37 days. It's a very long period. There's some therapy continue, and here is good not only for the patient, because you take care every 7 days, but you put inside 100 milligram of the hyaluronic acid, and you put inside 10 milliliter, and you change all the synovial fluid inside of the knee joint. But sometimes it depends on the patient. Sometimes we have the patient who don't like to be injected every 7 years. It is the reason why we use only 1 shot for 1 year and nothing more. In Macedonia, for example, I work in Skopje. When Macedonia is a small country, but when some patient have obligation to come every 7 days from another city, maybe 200 or 300 kilometers, for us is the big distance, and they pay for the petrol, for the benzene, like economic problem, it's very useful to put a single dose, single shot.
Thank you very much, Professor. Thank you very much. And there's another question. How many times you need to inject Optivisc single? From your experience, of course.
Done. When we talk about the hip joint, exactly 1 time per year. That's enough. And after 1 year, strictly, I don't know what happened inside, the patient come to ask me to put another injection. Strictly 1 year. But when we talk about knee joint, I don't wait 1 year, maybe 8 months to put another, because if the patient is good, he know, we measured with a VAS scale, but the first pain in his knee joint, he have afraid that maybe will be better to put another injection. They come alone without any protocol, and I will put after 8 months another injection. Sometimes after 6 months, no problem.
Okay, so the last questions, of course, rest of the questions will be asked after whole webinar. So we will try to get those answers together and send to our participants that ask those questions. So the last question, is hyaluronic acid recommended for severe osteoarthritis?
Very severe osteoarthritis, you know, is indication for implantation of total knee prosthesis. But in the situation when we have a comorbidity or anesthesiology contraindication to put it, we have not any possibility then put viscosupplement. Maybe it is the reason why in severe osteoarthritis we put Optivisc single. Believe me, in my personal experience, I have a patient who had osteoarthritis, coxarthrosis, but dysplastic coxarthrosis. It's not really indication for viscosupplement, but he's very young. He don't want to be operated. The indication is total hip prosthesis, but he don't like to be operated. He want to be active with dysplasia or not. And we every 6 months we put Optivisc single because this is a quality of life. In that case, I accept the story of my patient, and in that only in the end, in situation only have contraindication to put the total knee prosthesis.
Thank you very much. There's a very interesting question came up, so I will ask, and this will be the last one. I will get to our next speaker. Is it safe to combine PRP with Optivisc, the platelet-rich plasma with Optivisc? And do you have any experience with this kind of regimen?
Yes, I have. All the patients who have operated arthroscopy with cartilage damage, we will start with viscosupplement. And after 1 month, we continue with PRP. Because if I use Optivisc single for 1 year, 1 shot, it's possible to mix with PRP and PRGF. I call this type of therapy sandwich therapy. The result is very good up to now, especially when we talk about VSCL. No second view arthroscopy, very, very rare to put arthroscopy have some kind of damage of the meniscus, but VSCL give a good result and LISCOM score too. And it is the reason. Then arthroscopy, then Optivisc single, and after 1 month, we start with PRP. Maybe 2 or 3 shots is depend of the damage.
Okay, thank you very much, Professor. Thank you again for your wonderful presentation. Thank you for all the answers for the questions of our audience. And now I would like to warmly welcome Professor Chowdhury Mahmood, Associate Professor of Orthopedic Surgery in, I hope I will not make any mistake, Medical University Hospital at Dhaka, Bangladesh. He's made his post-graduation in UK and his fellowship in Singapore and Korea. And he's practicing as a knee and arthroscopy surgeon for the 15 years. He will be presenting his presentation about arthroscopic ACL reconstruction with 5 strands hamstring autograft. So please welcome Professor Chowdhury Mahmood and his presentation.
Can I audible? Am I audible?
Yes, we can hear you loud and clear, Professor.
Okay. Good morning, good afternoon, and good evening, wherever you are. I'm Dr. Mahmood. I welcome you to today's session. I hope you are all in good health and safe in this difficult situation. My topics is a little bit different from the others. I'm going to discuss about the arthroscopic anterior cruciate ligament reconstruction with 5-strand hamstring graft. I have no disclosure. I work in Bangabandhu Sheikh Mujib Medical University. This is the largest hospital and multi-specialty hospital. And I privately practice Green Life Hospital. So I start with the very wonderful definition by Freddie Fu of ACL. That is, the ACL is a dynamic structure rich in neurovascular supply and comprised of distinct bundles, which function synergistically to facilitate the normal function of the knee with bony morphology. And it's characterized by individual uniqueness. That is, is inherently subject to both anatomic and morphological variation as well as physiological aging. We all know that ACL injuries are very common. Even in the States, there are 200,000 new injuries per year and 100,000 ACL reconstructions per year. In Bangladesh, the number is increasing due to participation of more and more people participate in sports, and also there is increasing number of motorcycles in the streets, and the number of accidents also increasing. So why we want to treat a ACL deficient knee? Particularly say if it is indicated, surgery is indicated. If we do not do the surgery, then it will progress. It ultimately the progress to symptomatic instability. There will be recurrent injury, and there will be associated meniscal damage, and ultimately it will cause arteries. So a little bit of anatomy. We all know that ACL has two bundles, one AM bundle and PM bundle, and both the bundles work synergistically, and this is not a isometric structure. That is, during the different range of motion, the different bundle length and tension changes. So this is not isometric. Here you can see the AM bundle and PM bundle. AM bundle, particularly tight inflection, it receives the anterior translation, and the PL bundle mainly receives the rotation at the end of the extension. So PM and M bundle, they work synergistically to prevent anterior translation and some rotation. So what's the aim of our ACL reconstruction? Obviously, we want to stable and increase the strength of the knee. We make our patient to return to sports and activity, and we also want to delay the OA to protect the cartilage. And ultimately, our aim is the patient satisfaction, so that they can go to their pre-injury level. They can participate to sports, and again, they can participate their daily recreational activities like that. Successful ACL reconstruction depends on mainly three things: the high strength graft, anatomic positioning, and proper fixation. There are several graft options. Actually, the ideal graft should be capable of withstanding the translational and rotational stress of the knee, allow for ingrowth in the bony tunnels, limit perioperative donor side morbidity, and allow for early aggressive rehabilitation, technically reproducible. One of the most concerning point is that it should be minimizing the donor side morbidity. And I think till date, there is no such ideal graft. So there are multiple graft options. Some are long, some are diameter is higher than the others, some are strong. So main grafts we use usually, there are autografts and allografts. Among autografts, there are bone patellar bone tendon graft, hamstring grafts, quadriceps tendons, and peroneus longus. Allografts, actually in our country we don't use allograft, we don't have allografts. So we mainly use, in my practice, I mainly use hamstring, then quadriceps, then bone patellar bone. So why hamstring graft is so popular? Because hamstring graft has several advantages. It is stronger and stiffer graft. Smaller incision, the better cosmesis, can be used in skeletally immature patients, and less donor cell morbidity. And what about bone patellar tendon bone graft? Is to harvest, but the main disadvantage, particularly in our context, there is the chronic anterior knee pain, because in our culture and in our religion, we have to kneel down frequently. So knee pain is a very much big concern. Other than that, there is a risk of patellar fracture, patellar tendon disruption like that. And if you compare the bone patellar bone tendon graft and hamstring tendon, you can see that the outcome is almost same. And if you look at the hamstring guard, it's a 4 strands single bundle hamstring graft. That is the ultimate tensile load is higher than other graft. So why we want to use 5-strand hyaluronic acid graft? Because in our country, it's very difficult to get more than 8 millimeter graft even after quadruple strands. So we have 4 options available. Either we have to use bone patellar bone graft, or quadriceps graft, or peroneus longus graft. But I recently started from using a 5-strand hamstring graft. So it will make a graft more than 8 millimeter. 5-strand hamstring autograft. If we 4-strand hamstring autograft is common choice, but there are some disadvantages because for the hamstring graft, because it's inherent variability in graft diameter, and MRI doesn't predict the diameter of the graft before surgery. And biomechanical testing has shown a correlation between graft cross-sectional area and maximum load to failure. And several literature suggests the recommended diameter for successful ACL reconstruction at least 8 millimeter. And hamstring autograft diameter correlate with the patient's sex, age, height, body mass index, thigh circumference. Biomechanical studies have demonstrated that strength of graft tendon is related to its size. So these all factors are actually unpredictable. And majority suggests that the size of the hamstring autograft it's very important to avoid failures. And minimum less than 8 millimeter graft, more than 8 millimeter graft is required to decrease the rate of failures. Because larger diameter hamstring graft not only makes the graft stronger, but it also replaces the higher percentage of attachment size. And this is a big study which shows that graft size independently doesn't affect the revision, but its diameter of the graft matters, and hamstring graft diameter more than 8 millimeter reduces ACL's revision rate.
Those with larger autografts, hamstring tendon
There is another 2 good studies which shows that the hamstring graft lesser than 8 millimeter, there is increase in ACL graft failure. There's another Moon study which also shows that graft lesser more than 8 millimeter graft, there's a 5-strand graft associated with decreased failure. And if you compare 4-strand with the 5-strand graft, the outcome is almost similar. It's better in 5-strand graft, and revision rate is also lower than the 4-strand hamstring graft. So how do I do it? How do I do the 5-strand hamstring graft? The key to make the 5-strand graft is the length. You have to take the hamstring graft should be at least 24 centimeter to make it 5-strand, and then so that in the femoral tunnel you could get only 25 to 30 millimeter. Then intra-articular portion will get to 25 millimeter and rest in the tibial tunnel. There are different methods of making this 5-strand hamstring graft, but these are the portals I use: high anteromedial, accessory anteromedial, and then anterolateral portal. And the graft harvest, we all know that. I'm not going into details of this. I just show the technique. I follow the technique by Kyle P. Jeffrey, where after harvesting the graft, the one end of the semity, after which stitch the both side, one end of the semity is tied to the loop of the in the button. Here you can see in the video. Then the loop pass. Then the rest of the folded the semity graft and passes through the loop to make it 3-strand. So initially, you have to, after making the 4 strand, you can measure the graft. If it is less than 8 millimeter graft, then you can go for 5 strand graft. So the loop, now the semity is passing through the loop of the endobaton to make it 3 strand. Then the gracilis is then passed through the loop and make it 5 strand, and then measure the graft through the sizing. Ultimately, we can get more than 8 millimeter graft. Measure the graft. It's minimum 8 centimeter length and 8 millimeter diameter. Then procedure is like it's like the same like a 4 strand graft. You have to make the femoral tunnel through accessory femoral tunnel. You can pass a spinal cannula to mark the side of the femoral tunnel. Here you can see the femoral tunnel, femoral footprint. It's a chronic case, so there is some footprint issues there. We all know that the femoral footprint, the bony landmark is lateral intercondylar notch and bifurcate notch. So I'm not going to detail. So after finding the footprint, this is another case, just shaving the remnant tissue to clear the femoral footprint, and then localize. This is from the anteromedial border. Localize the area of the entry point. Just it's lower, a little bit posterior. Anatomical position. If you have the footprint, then it's easier. Otherwise, you have to follow the ruler method or any other X-ray fluoroscope method like that, or the bony ridges. You have to use the bony ridges to find the accurate position. After making the femoral tunnel, then the tibial tunnel. You all know these things. Yes. Femoral tunnel is anterior border of the lateral, anterior border, posterior border of the anterior of the lateral meniscus. Yes, lateral to the medial tibial spine, something like here. To just remember that to avoid the anterior of the root of the anterior of the lateral meniscus, you can make the tibial tunnel is just a little bit medial to the root. So here you can see the graft is passing through the tibial tunnel to the femoral tunnel. Okay, and the tibia is fixed by BioTech screw. This is the pre-op graft test, and this is after reconstruction, the Ligament test. So rehab is particularly same like the 4 strand graft. First week we make sure that there is less pain, less edema, and I started weight bearing the first day or day after the surgery, and allow range of motion exercise as tolerated. Then after 3 weeks, 2 weeks, started gradually strengthening and range of motion exercises. So we have a study where we studied 120 patients, among them 100 male and 20 female. We did ACL reconstruction with 5 strand autogenous hamstring graft, and the result is quite good. I mean, 60% excellent and good, 35% fair, 5%. The findings of the the patients, the interesting is that these are the ACL injuries. And pre and post-operative graft diameter, red is the post-operative, yellow is pre-operative graft. That is significantly increase the graft diameter. Like 4-strand range is 5 to 8 millimeter, means 6.5. But after making 5-strand, it significantly increases the graft diameter 7 to 9.5. And these are the number of patients with the diameter of graft. There are more than 9 only one, and most of the patients are around at 8.5 millimeter and 8 millimeter. I had a chance to look at one patient because he had a meniscal injury, so I had to go in. So this is the 5-strand hamstring. You can see, you can appreciate that nicely ligamentized with good blood supply. So in conclusion, graft size in hamstring autograft ACL is an important factor directly related to failure. Exact graft size recommended to avoid a risk of failure is still a topic of debate. Several methods that are simple and reproducible have been published. Graft size of more than 8 millimeter provides better knee stability and higher return to sports and lower revision. Thank you very much. Thank you very much.
Thank you very much. Thank you very much, Professor. It was really nice to hear and see your presentation. Now it's time for questions. I have already received some of them. I will start with the one. Use your experience about use of hyaluronic acid after ACL reconstruction. Your experience, does it work, when to use it, and how many times? That's the first question.
I usually don't regularly use, but I started using hyaluronic acid for the last 2 years. And most of the cases where there is associated chondral injuries, like grade 1 or grade 2 Optivisc, grade 1 and grade 2 cartilage lesion, I regularly started using hyaluronic acid, and I use that is the high molecular weight once yearly hyaluronic acid for 3 to 4 years, and okay. The result is quite good.
Very good results. Yes. Okay. Thank you very much. Another question is. Am I right? Moderate ACL and mild MSL tear. Can I use Optivisc single? Moderate ACL and mid MCL tear. Can I use Optivisc single?
Actually, it depends whether what grade of injury is there. Whether it's a complete tear or partial. I don't know what's the type of tear is it. But if it is a complete tear, you have to reconstruct first. Then you can use hyaluronic acid or like that. But in case of MCL, most of the MCLs actually healed by conservative treatment. But in case of grade 3 or chronic grade 3 MCL injuries, we usually reconstruct MCL. But I don't have any idea, is there any role hyaluronic acid for MCL? I think Professor, do you have any idea, any experience regarding hyaluronic acid in MCL tear?
Okay. Another question is, to what age would you recommend an operative treatment? Individual differences?
In case of ACL reconstruction.
Okay. STG versus all inside, only STG graft. The person that asked saying that they work with all inside ST graft with 2 endo buttons. Do you have any experience with QT?
Yeah. I use QT, but we don't use all inside ACL reconstruction. But I use QT particularly when young active patient who wants to play contact sports, in that cases, I use quadriceps without bone block or sometimes with bone block.
Okay, what is your opinion, experience about superficial QT graft?
Yeah, even you can see even in the literature, this is getting very popular days by day, the quadriceps graft, and the indications are also increasing. So my experience is quite good. I mean, in young and active patients, if we use the minimally invasive procedure for graft harvesting, I don't find any quadriceps dysfunction after QT graft using. So my experience is quite good. The result is quite good.
Dr. Chaudhary,
Yes.
if I can share my experience.
Yeah.
Yeah, I have started using peroneus longus as a primary graft for around last 14 months. Now we are gathering the data. It's now more than 100 patients. And as far as the foot and ankle score and overall ankle function is concerned, there is not much of the problem we have found out. So usually Dr. Bancha and other people who are propagators for using it, keep it in reserve for revision surgeries. I have started using primary, considering if we can use for second means revision, why can't we go for primary? So that was the concept. So even peroneus longus is very thick graft, very robust graft, very easy to harvest, and less connected with the mainstream, and there is no kind of paresthesia what we find sometimes with hamstring graft, like we find with the TKR, that there is no paresthesia. So that is another advantage of peroneus longus graft.
Yeah, that's true.
What we do is when harvesting longus, we tie the distal end of longus. Yeah, longus and brevis both.
Yeah, even I did quite a number of cases, but I still prefer hamstring for primary cases. And even in the literature, particularly in the Asian countries, the peroneus is getting popularized day by day for primary cases.
Yeah, primary cases.
That's the best part of webinars, where two professionals can change their experience and make a discussion. That's a great.
Dr. Glasgow wants to say something.
A great thing.
Yes.
Yeah.
What is my opinion? Choose the patient, choose the graft. It's not the same if some high-level athletes have 100 kilo to put a hamstring. It doesn't work. I use BTB. Really BTB. Professor Ramon Cugat has interesting analysis from the footballer of Barcelona. In a football club in Barcelona, according to Cugat, Ramon, they said 10 football players operate, 7 with a BTB graft and 3 with hamstring. And all the 7 football players continue with the sport activity, and 3 of them no. It's not the same when we have a small girl with a 40 kilo and not sport active. To put BTB is not possible. She has a small patella, risk of the fracture, and etc. etc. In this case, I use hamstring. A tightrope PRT is very nice to make ideal position, not of the graft, but press width of the graft, and the result is good. But choose the graft, choose the patient. Depend of the demanding of patient of rest of his life.
So, how percentage of your patients get BTB graft as a primary ACL reconstruction? How percent of patient do you use BTB?
All the patients who have more than 80 kilogram sport active and young, I use BTB. I use BTB one small series after 50 years old. They have arthrosic pain and it's not good. In a patient who have 60 years old, like me, is perfect hamstring graft. It's perfect. Very big, faster rehabilitation. It is good. I'm not very sport active now.
Yeah. I also use BTB in case of whether it's medial side injury like MCL injury or in case of active and robust patient. I sometimes use BTB, but the main concern in our country is that everyone wants to kneel down during religion for religious purpose or cultural purpose. So we try to avoid BTB most of the time.
Mahmoud, first of all, I would like to thank you for the nice presentation.
Yeah,
technique with the 5 strand is good, but I have some interest in that. Do you have some risk of Cyclops syndrome because you put 4?
Yeah, because you know, in our country the people are so small. Even after making 5 strand, we hardly get 8.5. So it's not a problem, I think.
That's what we saw, that your average time is,
even after 5 strand, you hardly get 8.5.
Yeah.
So I don't think it's a problem.
Okay.
Yeah.
Thank you very much for the discussion. That's a wonderful thing where great professionals can exchange their experience. So thank you for the questions for Professor. Now I would like to warmly welcome Dr. Pritesh Shah, a knee shoulder surgeon at Ahmedabad in India, trained with such a professional like Dr. Joe Deber from South Africa, Dr. Mark Ferguson from Singapore, and Dr. Kim Se-ho from South Korea. He's practicing for over 20 years, and he will be, his presentation will be about usage of hyaluronic acid outside of osteoarthritis. So warmly welcome, Dr. Pritesh.
Thank you. Am I audible?
Yes.
Yes, we can hear you loud and clear.
So my today's talk is regarding hyaluronic acid uses other than osteoarthritis. Thank you, BioTech, for inviting me. So my main focus will be on shoulder. I use for frozen shoulder very frequently hyaluronic acid. Around more than 250 frozen shoulders I have injected so far within last around 12 years. Initially, I was using low viscosity injections where I had to go for 3 to 5 injections depending upon the severity of stiffness. Later on, single shot injection was available. Then we started using that, and results are better with high viscosity injections. Single shot is better because less frequency of injecting in the joint, so less chances of infection, better compliance of the patient. It's very cost effective, and there is better viscosity. How does it act? It produces capsular distension. That's why it increases the range of motion. People are using saline also as a part of capsular distension. Prevention of adhesions, lots of trials are done on rabbits after tendon injuries, and they've injected hyaluronic acid in around the tendon and around the sheath. So they found out that there is less chances of adhesions and better healing after repairing the tendons. It acts as a counterprotective, especially when using with depomedrol, because I am always skeptical about depomedrol effect on cartilage, especially in the knee. But even for the shoulder, I would like to inject sodium hyaluronate along with the depomedrol if I'm going to inject. My technique, how do I do it? Ultrasound guided is the best technique. If you have locally available ultrasound, then it's good. If not available, then go clinically. How to go inside, I'll explain. Pre-injection inquiry about allergic reaction to sodium hyaluronate should be done. Pre-injection consent is must. 2 centimeters down and 1 centimeter medially from posterior corner of acromion. Feel the soft spot like this. Put the thumb on the soft spot. It is between the teres and the infra. And put the middle finger on the corrugate process. So that's how you can feel the ballotment. direct the needle towards the coracoid process. The moment the capsule is pierced, patient feels the pain and even surgeon feels the giveaway sensation. Usually I take 22 gauge needle, 1.5 inch long. In obese patient, I use spinal needle. Be cautious for vasovagal, especially when you are injecting in a stiff shoulder, very stiff shoulder. I usually prefer to inject in emergency room or where my physician is available on the same floor. Many people use local anesthesia. I usually don't use local anesthesia. Best response you get is within the first 3 months of the symptoms in case of frozen shoulder. Maximum I use for stiffness up to 1 year, and I was able to get the result. Other kind of stiffnesses where I injected is post-traumatic, post-operative, especially after oncosurgery, post-MRM. We have oncosurgeons in our hospitals, so I get a lot of referred patients from them. Post-MRM stiffness of shoulder is quite common. Diabetic frozen shoulder, I usually tend to get less response with sodium hyaluronate. I don't know why, but that's the observation. Best results are got with the idiopathic frozen shoulder. Even in post-paralytic, I mean, after hemiplegia, if you go for sodium hyaluronate injection, you will be able to get the result. After post-myocardial infarction, again, you will get very good result. After rotator cuff repair, it's my routine practice to inject sodium hyaluronate at the end of 6 to 8 weeks. Advantage is better healing when I had certain patients who were injected and certain group of patients who were not injected, either because of finance or they were coming from the remote place, were not able to come for the follow-up. I have found that the results of range in form of range of motion was better where I injected sodium hyaluronate, and even the strength was better at the end of 8 to 9 months of the repair. And it gives less stiffness to the operated joint. That is another advantage of sodium hyaluronate. Again, I told that lots of articles are available mentioning that it provides, means it prevents adhesions. It provides lubrication. How it acts? It provides lubrication. The glycosamine glycans provides well-hydrated pericellular environment that is good for healing. Formation of collagen fibers, it helps in cell migration and growth factor binding. It helps in cell regulation by influencing ion transport, nutrient diffusion, and water retention. That's how it helps in tendon healing. I have experience of my all ligamentous surgeries, my reconstruction surgery, they get sodium hyaluronate injection. That was again a question from the audience. So this is the answer. I inject after 3 weeks of any kind of ligaments operation. I think means ACL or PCL or ACL avulsions. After all kind of cartilage repairs, I mean, after ACI or after mosaic-plasty, I usually inject at the end of 6 weeks. I have injected even in metacarpophalangeal joints, 1 milliliter, that means 20 milligram. Even for the arthritic first metatarsophalangeal joints, I have many times injected tennis player, chronic injury leading to ankle arthritis, and they have come up with the very good results. Even young as 18 years old guy. So my experience in these patients is again good. Even in rheumatoid arthritis, I always try to inject after doing synovectomy. For the possible complications is extravasation. So if you are not sure whether you have pierced the capsule or not, whether it's knee or shoulder, be cautious before injecting. If the patient usually feels tremendous pain if it goes for extravasation. That is again a clue. I had only one patient in so many years where I extravasated the fluid. Patient had to be observed for 3 days with IV line, IV antibiotics. Ultimately, it went smooth. Allergic reactions so far I have never faced, but as per books, it is mentioned bruising and nausea and a lot of other things, vomiting. So better you ask patient. In India, it's not that common, but If they're coming from abroad, better to ask whether they're allergic to sodium hyaluronate or not. Infection, I have not faced so far, but again, a possible complication. So if not injected in a sterile condition. So again, let us see a small video. How do I inject? This is a patient operated for rotator cuff repair around 200 kilometers away, operated, presented at the end of 6 months to me with the stiff shoulder. Again, diabetic. I injected, very stiff shoulder. I injected 2 cc of dapomedrol. The needle was kept inside. This is again 22 gauge needle and followed by sodium hyaluronate. When there is a real stiffness, I try to put around 6 to 8 ml of the fluid, including dapomedrol as well as sodium hyaluronate. So you feel the posterior triangle of the acromion, then feel the soft spots, pierce the capsule. Painless flow is very important. That means you are in the joint, you are not extravasating. That comes after a lot of experience. Thank you.
Thank you very much, Dr. Pritish, for your wonderful presentation. Now, again, it's a time to ask the questions. The first question is, do you have any experience in injecting hyaluronic acid other than hip joint, knee joint, and shoulders? Probably.
I already mentioned that I have injected in metacarpophalangeal joints. I have injected in metatarsophalangeal joints. I injected in ankle. Ankle was quite frequent, and sometimes for elbow arthritis also, up to grade 3.
And the results?
Results are really promising.
Really
so
promising.
patient selection is very important. If you go for grade 4 arthritis, very old people, they will not respond very well. Patient selection is very important. Select young patients up to grade 3 arthritis, those who are ready to undergo very good rehab. And I usually inject them every year, single shot.
Thank you very much. We're still waiting for questions. Meanwhile,
can I ask a question, Dr.
Yeah,
Pratik?
yeah.
Yeah. Do you mix steroid with hyaluronic acid?
No. Dapomedrol, even not with local, xylocaine also, because before many years I came to know that it should not be mixed according to the literature, and so I stopped mixing. Earlier I was mixing. Then as far as sodium hyaluronate concerned, I inject first dapomedrol and then followed by sodium hyaluronate. But when I compare with the only dapomedrol and dapomedrol plus sodium hyaluronate, the results are definitely better with the combination. My lot of colleagues from my local town, they are not ready to agree. But once you have experience of your own patients, then only you will be able to comment. Because combination gives very good result.
The next question is from your opinion and your expertise. What should be optimum features of hyaluronic acid that should be injected to a shoulder?
Optimum is chemical formula wise, is asking.
Probably the molecular weight.
Molecular weight is going to be same between 4 to 6 million Dalton, around 3.5 to 5.5 is okay. But as far as the viscosity is concerned, my more reliability for shoulder is on the viscosity, not on the molecular weight. So I think BioVisc in India or at your place, I think is different, no? Which Optimisc, yeah. So it is called BioVisc in our place. So that is more than enough viscosity of your injection. So more than 500 Pascal is enough for viscosity. For shoulder, I would recommend go for more viscosity rather than concentrating on molecular weight.
Okay, thank you very much. How many cc of hyaluronic acid do you use to shoulder injections?
Earlier, I used to inject because like BioVisc, there was not availability of 90 milligram per 3 ml. So for that, I needed to inject around 6 ml of sodium hyaluronate. But nowadays, with your company is available, so the life is easy. Patient doesn't get into vasovagal because now less fluid is there, but it is between 3 to 6 ml, depending upon the viscosity and molecular weight.
Okay, thank you. What should be a desirable concentration of hyaluronic acid in injections when talking about shoulder?
Yeah, I explained, no?
Yeah,
I would prefer 90 milligram for 3 ml.
Okay. So you use the 90 milligram in 3 milliliters.
Yeah.
Okay, that's great. There's a question. Would you recommend Optivisc-90 in severe cases of...
I would recommend in all cases.
Yes.
Operated rotator cuff or operated adhesive capsulitis or idiopathic frozen shoulder. It gives fantastic result.
Similar question to those about knee. Do you have experience with mixing PRP with hyaluronic acid in the joint, in the shoulder joint?
I don't have any experience about PRP, but Dr. Zasko told that he has very good experience of PRP and visco.
Yes.
Okay. I will ask some questions that appears during previous presentations, and those will be open questions for any who would like to answer those questions. Do you find is there
sorry, Mr. Peter, and Professor Zasko wants to ask something.
Oh yes, please.
Oh, hello. Frozen shoulder is very difficult pathology. When I start to make arthroscopy of the shoulder joint, unfortunately, I start with a frozen shoulder.
Oh.
It's very difficult. It's very difficult. And I still prefer make fibrolysis inside, arthroscopy fibrolysis, sometimes anterior release, and manipulation of the shoulder joint. After that, I put only decomedrol. I never put, it is good experience to start to put inside Optivisc or hyaluronic acid.
Yeah, my experience is now reverse, Professor Zasko. Initially, I used to release the capsule, but now that rate has gone up to 10%. So 1 out of 10 of my frozen shoulder, I'll go for arthroscopic adhesiolysis. Means because of this capsular distension formula, we are getting tremendously good result. So what I do is first injection sodium hyaluronate plus depomedrol. After 1 week, second depomedrol, and third is depomedrol. Many patients don't come for second or third injection because they feel I'm 100% okay or I'm 90% okay. There is no need to go for second injection.
Okay.
But 50% of them get all 3 injections. But we have very good results, so much that my surgical rate has gone up to around 5 to 10%.
Bravo. Without arthroscopy?
Yeah, without arthroscopy, of course.
Okay, very good solution.
I think I learned from Dr. Jody Bear when I was with him. He was injecting a lot, around 30 injections in a day. And then I did for around 8 years. And then I realized, oh, this is a fantastic way of doing it. Why to operate all the patients?
Thank you very much. The another question is about the injection side when talking about shoulder. Anterior or more posterior? As we know, pathology mostly affects anteriorly.
Yeah, I would like to answer. I usually go posterior because posterior approach is very easy for me, being arthroscopist. My routine portal for inspecting the joint is posterior portal. And so I'm conversant with the posterior portal. It doesn't mean whether the pathology is anterior or posterior because ultimately it's intra-articular. So the drug is going to move around all over the joint. For anterior approach is just besides the coracoid, one need to go in the direction of glenohumeral joint. But personally feeling it's very painful to me, in my city, senior people are doing injection from anteriorly, but under short anesthesia, short general anesthesia. As far as my things are concerned, I never go for even local anesthesia. So for me, posterior portal is easier.
Thank you very much. Do you prefer making those injections in operating room environment with full septic, or
we have separate room for injections in my outdoor department, and is fully sterile. Every patient gets sterile treatment, and if you are not having that kind of setup, then you can take to operation room. And many times for insurance purpose, people inject in operating room because then they get reimbursement. But for me, outdoor department has full facility for sterile injections.
Okay, thank you very much. Now I will ask a few questions to anyone who's willing to answer. Do you have any experience in patients in injection hyaluronic acid to patients suffering from malignancy around the joint?
I have no experience.
Okay.
I have no experience. No.
Excuse me, Professor?
I have not experience.
Okay. What is the most effective treatment regimen if you practice with hyaluronic acid?
For?
What treatment regimen gave the best treatment results when we're talking about hyaluronic acid injections?
I usually go for
single, depending on.
I usually go for single shot since it is available, and I'm happy with that. Professor Zlatko.
It's mixed. It depends. I said now a lot of my colleagues in Macedonia and Bulgaria, they use a single shot. It's very easier. It's not very expensive to come to, for example, to Sofia, to Skopje every 7 days. But nevertheless, we have a good result with 5 shots every 7 days. It depends the patient, the possibility of coming to our clinic, or it's not easier to tell. The single shot is good.
I think it was another question. I think it was already answered during the presentation. Have you ever experienced patients with allergy? How did you handle it?
When you talk about allergy, we have not any case for allergy with this kind of hyaluronic acid. I have 2 types of allergy with hyalgan, but hyalgan come from animal production, you know.
Rooster's comb.
Yes.
I think we have some issues with connection.
The knee joint, the swelling the knee joint, the big knee joint, and hyalgan come from Fidia.
Fidia. I had been to Fidia.
We have 2 and very difficult allergy.
In 2010, I visited Fidia lab.
With a synthetic, no.
Yeah. With the bacterial origin, I don't think there's going to be any problem.
Thank you. Another question. Most of the patient improved with 3 doses of trimaquinolone. Hyaluronic injection is necessary.
Sorry?
Yeah, don't know how to. Most of the patient improved with 3 doses of trimaquinolone.
Yeah.
Probably is hyaluronic acid is necessary.
Yeah,
so,
I told already that it gives very good response if you go only for 3 doses of triamcinolone. But for severe frozen, severe stiffness, when I started using along with sodium hyaluronate, I started getting better results. So I would recommend that if you can use it along with dapomystrol or triamcinolone, is better you use it for first shot. Second and third, you can go away with steroid.
Anyone who would like to say something about on this question also?
Dr. Chaudhary.
Okay, so another question. Is it safe to say that we can inject Optivisc every 6 months?
Yeah, Professor told, no?
Yes, why not? It's safe. It's very safe.
Yeah, what Professor Zlatkos told, that for knee patients usually come after 8 to 10 months, that I have started feeling pain. That's again common with my practice. So for shoulder or other things, it's okay if you go for 1 year, but in knee, one can repeat, I think, after 8 to 10 months.
I'm agree.
Thank you very much. Another question. Sometimes after injection of hyaluronic acid, patients feel pain in the joint. How you will minimize pain?
Some patients have afraid. Psychologically, it's not very ready to take the injection in his body, you know. And if he's not ready, then I use first anesthetic, lidocaine or xylocaine. After that, I use Optivisc to minimize the problem of the pain. It's not big quantity of hyaluronic acid to have a pain in knee joint. Knee joint is too big joint. Only psychologically.
But shoulder, when you are injecting in severely stiff shoulder, be cautious for sudden pain and vasovagal kind of thing. So because we are usually injecting in sitting position, so out of 100, I would say around 10 people will feel severe pain when we are injecting in stiff shoulder. So be ready for all these things. And for knee, usually I try to get attention to other conversation with the patient, or you try something else and like that. And moment there you are in talk and your needle is in. But for shoulder, one need to be cautious.
So after injection, isn't it advisable to advise patient to icing, or isn't it?
Yeah, I usually ask for doing icing for around 2 days.
It reduces pain
for 2 days, and psychosomatic also. And anti-inflammatory, I usually prescribe for 3 days, anti-inflammatory.
So do you remove some of the synovial fluid to decrease the risk of big pressure inside the synovial joint before you inject the hyaluronic acid?
I never inject any warm joint, means any hot joint or anger looking joint, because when effusion is there, I usually try to avoid injecting viscous. What I ask the patient to go for more physio and compression bandage, and when they come in the follow-up with the less effusion or almost nil effusion, then I go for injection. I have never done removal of synovial fluid and at the same time putting the viscous inside. But Professor Zlatko, what's your opinion?
I'm agree with you. First function to solve the problem inside of the knee, to slow down the synovitis, and then after 1 or 2 or 3 weeks, it's possible to put hyaluronic acid. No insane time, never.
Yes.
The question is to both Professor and Dr. Pritish. Do you advise antibiotics after injection?
For diabetics, yes. For diabetic patient, 3 days. In Indian scenario, it might not be common with other people. But for diabetics, I am a little bit afraid. So better to put them on cefixime or something.
Does injection speed, I mean probably the flow rate, affect post-injection pain for the patient?
Of course, of course.
How long those 3 milliliters in case of 3 milliliters injections? How long approximately it takes to make those injections?
For me, around 30 to 40 seconds.
Okay.
For others, yes. Dr. Charlie?
Professor Tamakowski, any experience on this?
How long is
how long you are making those injections to the joint, and is this injection time affects pain feeling for the patient?
It depends of the patient, but in a second, maybe 10 seconds, maybe 12 seconds. I never measure it. It depends of the second of the patient to talk with him. What is that? Did he have a pain? What is the situation now? And we have a different patient, and it is the reason. Sometimes is very quickly. It means 10 seconds. And if I put very, very quickly, and in that cases, you have some kind of pain. If it's slowly with a single shot, it's very slowly forever. And maybe it's 10 or 12 or 20 seconds. It depends of the patient.
For knee, I usually go from medial parapatellar approach. And what I usually do is try to avoid touching anywhere in the bone or cartilage, I mean. Moment your needle touches the bone, the muscle goes in spasm.
Yes, I know.
And then the space is reduced, the patellofemoral space. So better to feel it first with the thumb, medial patellofemoral, because it's usually laterally tilted. So you get, because initially, before many years, we were injecting from the lateral side. But moment I started using from medial side, the same way we were putting drain in the TKR. So the medial space is very much open and you can easily go in. And moment the capsule is gone, you are safe. But beware that it should not touch the bone or cartilage, because then it goes for spasm.
Yes, the main problem is when some kind of resident of debutant start to put the injection and make some damage of the cartilage. It is the real pain.
Yeah.
It is real pain, real damage. But now we have not a big problem about it. But not every patient is the same. I said many times. Especially the men in my country. Men, oh my God. The woman is very, very strong. Men, we have a problem.
It's reverse in India. It's reverse, very much reverse.
Probably we have many women at audience, so they will be pleased with those words.
Yeah.
Next question. What is infection rate after injection? What is your experience?
Mine is 0 after around more than 1,200 injections in so many years. But yeah. So nobody has infection.
Okay.
The most, excuse me, Piotr.
Yes.
The most important things. Every function of the articulation is possibility to make some infection. The preparation of the skin is most important.
Most important.
Because
we are going outside in.
Operation, like an operation, you must clean like operation field. Not to be only one alcohol and we will go inside. No.
Of course.
I have. Yes, you're right. I have got patients given injections, depomedrol in the knee from around 200 kilometers from my town. Patient came with the sepsis of knee. I had to do arthroscopic lavage and everything. But that man is still using alcohol swab. So again, these are the difficult things.
Yeah.
We need to really paint it and really a couple of iodine or anything, chlorhexidine things, and then clean up with the spirit or something, alcohol, and then inject. Means real way.
I agree with you.
Okay. The other question, there was a similar one, but now it's more specified. Can you give triamcinolone injection at the same time with Optivisc in the same syringe?
Same syringe. Syringe is already PFS.
It's not possible.
Yes. So maybe
No.
after injecting.
Same needle. What I sewed was the same needle.
Okay.
The needle was kept inside the shoulder joint. I took out the syringe of depomedrol, and I took the PFS of this thing, sodium hyaluronate, and then I injected from the same needle. But same syringe, there is no meaning of it. There is no purpose of it. Yeah.
Same syringe is not possible.
It's not possible.
It's not possible.
But it was a question, so I wanted to.
Better to avoid, spending few bucks for one more syringe.
Exactly. Dear speakers, dear doctors, dear professor, thank you very much for your time, for being here with us, for our audience. This whole webinar is being recorded, so this will be available soon after on YouTube. So if any would like to watch it again or forward this to their colleague, feel free and do it. As I said, some of the questions, because there's so many questions, some of the questions will be sent to our speakers and will be answered below the YouTube video, below the recording. So again, I would like to really thank to all of our guests for being here, for those wonderful presentations, for those great answers, and I really hope that you also enjoyed our webinar, and that we will have another opportunity, another chance to meet and present and prepare such a wonderful event again. Thank you very much.
Thank you.
Thank you very much.
See you, Professor.
Thank you. I would like to also thank the audience for the great questions, because we make our speakers to communicate, to make those discussions. This is a great moment of every educational webinar, educational event. So thanks to all of you, and hope to see you again.